Now we welcome back Dr. Shroff to talk us about the craniocervical head and neck arterial dissection in children.
Thank you so much. It was a great pleasure listening to Suresh. I'm sure you all are glad that I gave up my little extra time that I wanted on this. So I'm going to speak on arterial dissections in children. It's not just a grown-up problem. Pediatric arterial ischemic stroke is something that we are now very aware of. We don't think about it. And so this is a small subset of that etiology for pediatric arterial ischemic stroke. Compared to the adult world, where 99% of the time stroke is due to atherosclerosis, ischemic stroke, in children there are many causes, but cervicocephalic arterial dissections form about 1/5 of the causes. They are important. Vertebral artery dissection is the most common cause of posterior ischemic stroke in children, up to 40 to 50% of the times. And sorry. So there are some differences. For example, seat belt injuries, which cause cervical injuries to the children. Anterior dissections, when they occur in children, anterior circulation dissections occur more commonly intracranially. Remember that. Posterior cervical dissections, cervical artery dissections, vertebral artery, the outcomes are much better than the anterior circulation. And the presentations are different. Adults often present with neck pain, children often present with deficit for some reason. And in children, usually the infarcts are cerebellar or thalamic, whereas in adults, the classic vertebral artery dissection syndrome is the lateral medullary infarct. So there are some differences to remember over here. In terms of vessel wall anatomy, it's important to remember that the artery is composed of the adventitia, the media, and then the intima, which consists of the internal, pointer, sorry. Yes, there you go. What is very important is when you go intracranially, the adventitia is often missing, for example, the vertebral artery, and that's why the vessel is not as strong when it's in the neck, and that's why dissections, particularly for the vertebral artery intracranially, become more important. So think of that. The vessel locations where dissections occur, we know that in the adult world, commonly it's in the mobile section from, say, about C4, C5 upwards. This is a great website for dissections if you want to look at on YouTube. In terms of the vertebral artery, the location where dissections occur is very similar to adults. It's in this V3 segment from C2 transverse foramen to the point of entry into the intradural intracranial component. So this is a very vulnerable area for vertebral artery dissections. When we want to define dissections, when you want to define any disease, you have to have a standardized classification pattern and definition for diagnostic evaluation. Otherwise, literature keeps varying and you don't know what's really happening. These are two great papers, one in radiographics recently, and another one based on how to actually classify these dissections. So very simply put, in children, if you have a double lumen intimal flap or a pseudoaneurysm or crescent sign on T1 images, the hyperintense T1 crescent sign, that's a dissection. Segmental arterial stenosis in the craniocervical region with a clinical event less than 6 weeks after the diagnosis of this, that is an arterial dissection. And particularly in the vertebral artery, if you look at the site of C2, because it's such a classic site for dissection, stenosis or occlusion at that level, even without a history of dissection, is presumed to be, even without a history of trauma, is presumed to be dissection. So think of these criteria. Here are some signs, the intimal flap, and you can see it very beautifully over here on this particular image where you have a little line going in through the cervical artery. And you can see it over here on T2 images very faintly. Then this is a T1 crescent sign where there's an intramural hematoma, and the opacified lumen is much smaller compared to the bright intramural hematoma. So these are signs that we look at. These are just different cases of dissection that we have seen in our practice. This is a 10-year-old boy who had a headache after a hypoglycemic seizure, which possibly caused some trauma, and he developed a pseudoaneurysm and an intracranial dissection in the distal right MCA. And you can see that's the CTA, this is the MRA, and this was the angio which we used to embolize. Now this particular 6-year-old fell in the playground and had acute onset of torticollis and diplopia, and you see this huge aneurysm involving the basilar artery. And this we treated with a big basket of coils to deconstruct the aneurysm, and the child is still doing well, and the aneurysm is thrombosing over time. You can see this is the follow-up of that same treated aneurysm. This is another one which is very classic. The left PCA goes underneath the rigid tentorium, the Fox part of the dura. And sometimes because of trauma over there, you can get a PCA dissection, which has causes right PCA infarct. Sometimes these are often also present as dissecting pseudoaneurysms. And this was a 10-year-old boy who had some problems while on a roller coaster. This is another classic case, a 17-year-old right hemiparesis, 1 week aphasia. And you can see that the left ICA was not visualized on the MRA. And even in the neck MRA, you cannot see the left ICA. And then when you do an angio, you can make out that the left ICA was trailing into a string sign on the left side, which is very classic on angiography for dissection. From the right side, there was good flow into the left circulation. And if you look at this particular image, there's a double-barrel sign of 2 lumens with a intimal flap in between, very classic for dissection. Nowadays, we don't really need to do an angio to make this diagnosis. The same patient, we also did an MR, and we used vessel wall imaging, where I'll just magnify this for you. You can see that this was the intramural thrombus, which is the classic sign for an intra-arterial, intracranial dissection. So this was very classic for that. So we use vessel wall imaging quite a lot for dissections. And this is something that I've copied from the, early on in New York, there was this little grocer who used to sell donors, and this is the way they used to advertise. As you ramble on through life, brother, whatever be your goal, keep your eye upon the donut and not upon the hole. So what's important over here is to keep your eye upon the vessel wall, because that's where abnormalities often occur, not just on the lumen of the vessel. So that is vessel wall imaging in a short note for you. This is another interesting case. This was a 13-year-old with Tourette's. He kept recurrent snapping of his neck, and you can see what happened. The recurrent snapping at C3, C4 injured the vertebral artery, and I've magnified this for you, and caused a little intramural hematoma. And he presented with brainstem signs, which are pretty severe. You can see this occlusion of the basilar artery. There was a thrombus that formed here and floated up into the basilar artery. And this was a very interesting case because we wanted to actually do a thrombectomy on this basilar artery and remove it, but the parents took 20 hours to give us consent, which was pretty ridiculous. And I had to actually threaten them that we are not going to do anything, and then they agreed. So in the end, we did remove a small amount of clot. We couldn't remove everything, but still that opened up one of the ACAs, and the child started improving. So in basilar artery thrombosis, secondary to dissection, sometimes we'll do thrombectomies even if it is much later. This is another case which I remember very clearly. I was standing at the MRI reception, and this girl called Sunita, she was 13 years old, walks in with her mom, and I look at the history. There's some weird sort of eye symptoms. She looked completely normal. But when we did the MR, we were really surprised. There was no basilar artery. There was a classic infarct on the left side of the brainstem in the pons. And this is an angio. Let me show it to you if it plays. Oh, I don't know why it plays. Let me try this once more. Duplicate slideshow. Yeah, maybe this will help. Yeah. So you can see how bad a dissection she had with a thrombus, which was floating on this angio. Now, when I did this MRA, I made one critical mistake, and this is something I wanted to show so that you don't make it. I didn't cover enough of the vertebral artery. You really have to go down to C3, because at C2 is where the dissections occur, right? And I thought I'd covered enough, and I called this that the distal vertebral artery is normal, whereas that is where the problem was. So don't make that mistake. This is another one, classic example. A Swedish boy who was 17-year-old came to visit Toronto, and he was really muscular. So that one day morning on August 11th, he gets up and does 2 hours of very vigorous, intense upper body exercise. And what happened is he becomes dizzy, and then we got an MR done, and you can see the infarcts in the left cerebellum, the thalami on both sides, and we can see there's a little thrombus sitting up in the basal artery over here on angio and on MRA. The rest of his vessels look completely normal. We looked very hard for a dissection. We couldn't find one. So our presumption is that because of his intense upper arm exercises, he stole blood away and caused some stasis over here with a thrombus. And I actually met the boy when he was leaving the hospital after 2 weeks, and he had recovered quite well. So this is just to tell you that basal artery stroke sometimes has better outcome in children compared to adult world, even with conservative treatment. Another important thing that I wanted to talk about is whenever you want to image the vessel, which is suspect, do it in a timely manner. And this is a very classic case that I'll show you. This was an infarct in the right posterior putamen. And you can see this little vessel over here seemed to have a little linear defect in it. And nobody believed me when I said, oh, this looks suspicious for an intimal flap, because it was too distal. Even I was doubting myself. I wasn't 100% sure about it. And you can see this is that same angio MRA, just to show you how that contour was different, and there was a little defect over there. Anyway, we followed him up further. Now, that same area, this was 1st January, this is 9th January. You can see that this looks like a beaded vessel and looks like a vasculitis now. Previously, it looked like a dissection. Now, if you follow this up further, this is 30th April. There is occlusion of the right MC, and if you had imaged at this time, you would think of embolic occlusion or a thrombotic occlusion of the right MC. So that, just to tell you that vascular abnormality is a very dynamic process, and it's important to image the vessel in a timely manner to get the correct diagnosis and appearance. Just one more thing about vertebral artery dissections and posterior circulation infarcts in children is always look for variations at the craniocervical region. And the more you think about it, the more you'll diagnose it. This is a 5-year-old on a trampoline who gets, a brainstem infarct. And if you look at his distal vertebral arteries, they were abnormal on both sides. And this is something which happens due to Bow-Hunter syndrome, where because of underlying predisposition and congenital abnormalities, when you turn your head too aggressively on one side, you compress the artery and damage it, and that is what was happening in this child. So every year we diagnose a few cases of this because we look for it actively. Previously, it was very rare for us to make a diagnosis. So this is the same child. You can see that head turning to the left was occluding this artery completely. Head turning to the right was occluding this artery completely. So think about that. This child had an abnormal occipital C1 anterior fusion, which was possibly predisposing to this. Now, when we turn our head all the time in routine life, and I worry about it all the time now, but you need to practice for it like they do. This is a special form of South Indian dance where they practice their head turns very nicely. So about head turning, my family doctor actually was doing yoga, and he put his head down on one side for a long time, and he developed a basal artery stroke and infarct. Can you believe it? So I really worry about turning my head a lot. Oh, this is another case that I wanted to share with you, a 10-year-old, and it's a very sad case. It's really sad. So this was a nice summer in Toronto, and the father takes this girl to the swimming pool, a community swimming pool, and within 15 minutes or 20 minutes of her being in the pool, he finds her struggling. He jumps in, pulls her out, brings her to sick kid. This was at 6:30. He saw her by 7:15. We are doing a CT, and we see this hyperdense MCA and a big low-density infarct. We do an MR just about 2 to 3 hours later, and there's a huge infarct, and the right MCA is really bad. So we do a CT angio, and you can see that one of the lumens is thrombosed and one is patent, so classic for a dissection, right? Intracranial dissection again in a child. We follow up, and because there was malignant MCA infarct, we had to do a decompressive craniectomy, and next day she worsened with symptoms on the other side. And I couldn't believe my eyes when I saw a hyperdense MC on the left side. I thought I was being fooled by the low density. But anyway, that is what it was. There was a left-sided MCA dissection also. So she unfortunately passed away, and because she passed away within 24 hours, the parents agreed to do an autopsy to see what had happened. This is the basal artery. This is what the normal intimal flap intima should look like, right? Internal elastic layer. And this is the proximal right ICA, and you can see there is congenital hyperelastosis of the internal elastic layer. And this was the right MCA, which I showed you as a dissection. You can see how the internal elastic layer is completely dissected to the other side, and the thrombus, and this is the thrombus, and the lumen is completely narrowed. So whenever we talk about minor trauma causing dissections in FOX, there's often an underlying predisposing factor, which could be congenital, something which may have caused this. So think about that. Now, when you think of outcomes and treatment options in dissections, endovascular treatment, again, plays a big role in addition to antiplatelets and anticoagulant agents. And I'll just show you one really extreme case. This was a Menkes disease patient who had this large growing pulsatile swelling in the upper neck. And you can see the abnormal vessels in Menkes disease. Now, we know that the outcome for this disease is terrible, but the parents did not want their child to die from a blowout of that aneurysm, and they wanted us to treat it. So this is the yin-yang of the pseudoaneurysm flow within the aneurysm. And we had no other option except to directly puncture it and then embolize it with coils and glue. And we got part of it sort of under control, and ultimately that completely thrombosed. And this is the follow-up of that ultrasound, which shows the flow going away. So thank you so much for listening to me for this talk. And thank you for staying to the end.
Thank you, Dr. Shroff. We are moving on to the next lecture, Pediatric Head and Neck Emergencies.
Thank you. And thank you all for staying with me to the end. And again, I want to thank the organizers. This has been a wonderful conference. Really enjoyed it. And I hope that my lectures made some sense to you. Okay, we talk about pediatric head and neck emergency. So this is a really vast topic. What I'm going to do is I'm going to just do it as a case-based presentation. Before I go forward, I just wanted to introduce my hospital again. This is a photograph from the history books of the hospital from 1897, where this gentleman is taking an X-ray of the foot of a child, a named child. Now remember, X-rays were discovered in 1895. Within a year or two, we get an X-ray machine shipped over, and you can see there's no protection, nothing, and we're using it in the hospital. So that's how long the tradition and history of radiology is in our hospital. So we will show you some cases about head and neck emergencies in children and focus on trauma, infections, airway obstruction, and a little bit about vascular lesions. So I show you this case one. It's very interesting. Many Canadians in the winter often go to the Caribbean or Mexico because it's so cold. So it's a very common thing for us to do culturally. So this 8-year-old went with her parents to the Caribbean, and she was swimming in the ocean when she felt a sudden eye pain. She was transported back by air ambulance to Toronto, and we imaged her. This is her bone image. This is her MR of the orbits, and you can see there's a lot of streakiness of the fat. There's something going on over here. And you can see there's also a bright spot in front of the pons on the right side over here. And if you look carefully, there's some sort of density over here which was very sharp and pointed. And then on asking some more history, she told us that something poked in her eye. She doesn't know what. But in that area is what you have, these called needlefish, which suddenly will come, and there are some case reports of this. This is not the only case that I have, which they suddenly hit you in the eye, and that went all the way in up to the brainstem and caused this problem. So, and I think one of the things broke off over here, and you can see that as a pointed thing. Now, if you look at this, the cavernous sinus on the right side also appears abnormal, so we did an MRA, and you can see some extra vascularity over there. We did an angio, and what is this? It's an indirect carotico-cavernous fistula, and you can see flow going across to the contralateral side, as was very well shown that the cavernous sinus communicates with the other side just below the pituitary gland. And how do you treat this? Yeah, just to tell you that she actually developed raised intraocular pressure on the left side. The right side could not be examined. It was so inflamed and swollen. And that's how we suspected a carotico-cavernous fistula and did an angio. So endovascular treatment for indirect CCF is very difficult. She had been started on heparin and anticoagulants because we were worried about the cavernous sinus thrombosis. So what we did is we stopped heparin to allow that indirect CCF fistula to thrombose, which worked very well, as you can see over here. And then we restarted heparin again because we didn't want the arteries to thrombose off. And at 6 months follow-up, she improved a little bit, and she continues to do well, though on OCT, she does have optic atrophy. Okay, let's come to case 2. And this is a very interesting one. It's a very simple case, but it's an unusual sort of cause for this. So at day 1, this 3-year-old presents with eyelid swelling, and you think of, okay, it's like preseptal cellulitis. What are you worrying about? Second day, it increases a lot, and the eye seems to be popping out. So that's when we jump in and we do a CT. And this is a case that we are publishing because of its unusual cause. So you can see this phlegmon. You can see the thrombosed superior ophthalmic vein, which is also engorged because of the thrombus. Compare that to the normal left superior ophthalmic vein. And you see certain areas of much more lower attenuation. So we think this is a phlegmon with an abscess. You can see cavernous sinus thrombosis over here, and jugular vein thrombosis because of the infection that proceeded so rapidly to cause septic thrombophlebitis. This is an MR, and here I want to say that we made a mistake. The fellow on call used EPI diffusion, so we really did not get good diffusion images to show you diffusion restriction. Normally, you should do non-EPI images for anything outside of the brain to look for true diffusion restriction. But anyway, they went in and operated, and they found that these small pockets were pus. They drained them, they were abscesses, and the rest was phlegmon. What was interesting was that the cause for this was not rhinosinusitis or from the paranasal sinuses, which is the common cause for orbital cellulitis and abscess. It was mastocytic middle ear infection, Petrus epicytis, including inner ear abnormal enhancement. And that was the cause that went in forward into the cavernous sinus, superior ophthalmic vein, and then into the orbit. So it was an unusual cause for orbital cellulitis. This is case number 3, and I just wanted to show this to you because it's something we come up with very regularly. So this is obviously ethmoid sinusitis, and you can see that there is extension through the lamina papyracea into the medial aspect of the orbit. And this is a classic subperiosteal orbital abscess. This is often treated with antibiotics, and most of them do very well, except when they start having proptosis, gaze restriction, or if they're very close to the apex of the orbit where they could compress the optic nerve, then they would jump in and operate so that there are no complications with the optic nerve. Staphylococcus aureus is the most common pathogen in these. And remember, many people, when they image, they often say there's dehiscence or there is lucency. The lamina papyracea is very thin. It has multiple lacunae and veins going through it. So don't comment on the lamina papyracea as being osteolytic or like broken or something like that. This is our case 4, and I wanted to show this to you because there are 2 critical findings over here. Well, 1 critical finding and 1 classic diagnosis. So right-sided proptosis. Can somebody tell me what's the critical finding over here? Look at the right eye. So this was multiseptated, fluid levels, hardly any enhancement. I think you know what the diagnosis is, but what is the important finding over here? Look at the tenting of the right lobe. That is risk for acute loss of vision. So this was a classic sort of orbital lymphatic malformation with hemorrhage. And in this case, what we did is our ophthalmologist did a lateral canthotomy, and the interventional pediatric radiologist put in a needle and drained out all that stuff and put in, I think they put bleomycin in this. And we had to do this 2 times. The child is still doing well. We regularly follow him up. You can see the eye over here, pre and post-op. This is with consent of the parents that I'm showing you this picture. So this orbital compartment syndrome, that tenting is very important. Some people have called it as a guitar pick sign because on ultrasound, it looks like a guitar pick like this, the eye globe. So think of that as something which is at great risk for acute vision loss, and if not addressed promptly, can lead to ischemia and permanent vision impairment. So if we come to classic diploic hemangioma on the skull X-ray, and you're wondering why I'm showing this very simple, straightforward case to you. But this child also presented with decreased vision on both sides over the last couple of days. And this is the classic diploic hemangioma. And the reason for that was if you look at the optic nerves, you can see the distended optic nerve sheaths over here. And what this hemangioma was doing was compressing the torcula, causing raised venous pressure within the brain, then leading to bilateral papillary edema. So this was embolized by us, and the surgeon could take out the whole thing en bloc, and the kid did very well. So those were some orbital emergencies that I showed you. Now we'll get over these orbital emergencies and move on. I want to talk about plain X-rays, something basic and simple, but something which we should never forget, the classic epiglottitis that we see. One thing to know is that when you think of croup, it is hypopharyngeal distension, whereas this is more about that, and you can see that classic sign, the croup steeple sign that we see. This is compared to normal on the frontal view. But more importantly, what I want to say is if you suspect epiglottitis, there's drooling and pooling, and you want to take an X-ray of the child, don't put the child supine, because it could obstruct their already narrowed airway, and suddenly you'll have an emergency on your hand where you have to save the airway. So think of that. This is case number 7, just to show you, sometimes how people miss things in the community. This was reported as normal by a radiologist that I knew, but I knew that he had reported some 300 plus X-rays that day, and this came in his routine file. And what is the diagnosis over here? You can see that fishbone, and when you see air within the retropharyngeal soft tissue, that is pathognomic for an abscess. So this was a foreign body with a retropharyngeal abscess. So with that, we come to infections and the airway. This is a young kid with URTI followed by acute deterioration and retropharyngeal abscess. And you can see that there are these bilateral collections separated by a midline raphe. This is classic for retropharyngeal abscess. One important thing to understand is the anatomy over here. So you think of the different components. The retropharyngeal space is something which is between this red and the green line. The posterior forms the alar fascia, the anterior is the buccopharyngeal fascia, and between that is the retropharyngeal space. And when you go posterior to the alar fascia and before the prevertebral fascia is a danger space, you should know about this because you want to think of the danger space infections also. I just put these other 2 retropharyngeal abscesses over here. Sometimes there are suppurative lymph nodes which cause this. Sometimes they extend superior-inferiorly quite extensively. If it is more than 2.5 centimeters, usually they want to operate. But first, they'll always give a trial of antibiotics for 24 to 48 hours. And if the kid does not improve, then they go in and operate because it could compromise the airway. So this is a great paper that has recently got published by some of my friends in radiographics. And this is on non-traumatic pediatric head and neck emergencies. Please refer to this as and when you feel like. So this is an image from there talking about tonsillitis, phlegmon, abscess confined to the region of the tonsil, and a peritonsillar abscess. Remember that when you have neck swellings, there are different causes for lymphadenopathy. This is one rare cause, mycobacterial infection with these coarse calcifications, and these often drain into the skin, and these are often chronic findings. Let me show you this case. This is a case number 8, acute right-sided swelling at the angle of the mandible. Right now, we cannot say what this is. We treat it as an abscess. The child did well, but this is a follow-up after 3 months of treatment, and what is this? Classic second branchial cleft cyst which got infected. So yeah, we have to think of congenital lesions also. This is another case with otitis media, mastocytitis, rhinosinusitis, and intracranial complications. The reason why I show this to you is because, remember, there's vascular compromise and narrowing, so look for abnormalities in the vessel. There's one interesting fact over here that I just wanted to bring up, is that post-COVID, institutions across the world have started reporting an increased trend of intracranial complications. And the reason for that is supposed to be, there are 2 theories that they think of. One is immune depth, because children were not exposed to infections, so did not develop enough immunity to sort of take care of those infections, and that's why they have more fulminant complications now. The other sort of possible reason is because most countries have such a long waiting list that otitis and sinusitis is not a priority, so they don't get treated or diagnosed quickly, and that's why they present late with these complications. So that's something just to remember. Know these uncommon but important infections, very important. We spoke about the danger space. It is so rare nowadays, I couldn't find a case in my own files. I've seen one maybe several years ago, so I had to copy this from literature, where if it gets into the danger space, it goes all the way down into the mediastinum, and you get mediastinitis, like in this case presentation. Then know about Ludwig's angina. This is often due to odontogenic infection, where you get swelling of the sublingual space, and this can increase rapidly to compromise the airway. Then this is Lemierre syndrome, another important sort of infection where you get thrombophlebitis of the jugular vein, and you will often get a complication of pulmonary abscesses due to this. So think of these unusual infections. We come to vascular emergencies. Nawal, how much time do we have? Okay, perfect. Lots of time. So this is another case where you can see there's a big retropharyngeal abscess / phlegmon. If you don't look at it carefully, you would miss the pseudoaneurysm, which becomes very important to diagnose because this has to be taken care of. You don't want this to blow out. This is an obvious infection of complication. Of course, a large pseudoaneurysm secondary to an infection. This is a very classic case that I like to show. I was on call. There was a time when we used to do a lot of call overnight. So the fellow, who's now a great pediatric radiologist in the UK, was reporting this case at 6 a.m. And this child was running around with a pencil in his hand and fell. The pencil stuck him into the neck. And this was reported as a hematoma in the sternocleidomastoid, and the child was being sent home. I happened to come along, and I thought that the ICA looked a little bit weird to me, so I got some reconstructions done, and lo and behold, there was a little pseudoaneurysm over there. So whenever you stick anything close to a vessel within, say, 2 to 3 centimeters, always go back and look at it very hard. So this completely changed management. We had to call the vascular surgeons, and this had to be repaired, right? Here's another one, a very unfortunate case. The parent was walking with their dog, and then this, child, and this dog latched onto the right side of the neck, and by the time they let it go, there was a lot of damage done to the right side of the neck and a pseudoaneurysm of the right ICA, which had to be infected, and then very severe infective complications, which took several weeks to manage. Fortunately, the child did very well. So the moral of the story is anything penetrating close to a vessel, please look very hard for the underlying vessel. And it's great to do 3D and multiplanar reformations because small pseudoaneurysms you might miss. So this is another case, newborn with a right occipital mass. And you can see that I'm fascinated with hemangiomas. So this is a right occipital hemangioma, and you can see how vascular it was. Now, normally we would leave this alone, but what was happening is it was stealing blood from within the brain quite aggressively, and I'll show you that. There were multiple emissary veins. It was competing with venous outflow, causing venous hypertension. And you can see that the transverse sinuses on the right side was arterialized compared to the left side. This was the right occipital artery. And why bother about this? Because, if we let it go on to venous ischemia, we know from our vein of Galen experience that it damages the brain significantly and fairly rapidly. So we wanted to treat this. So if you look at this, I hope it plays. 1 minute, let me go here again. I realized that I need to do this. Yeah, okay. So this was a right-sided injection, and you can see how slow the venous filling is. And if we injected selectively into the branch supplying it, you can see that was most of the venous filling over there. So it was competing for venous outflow, causing venous hypertension and venous ischemia. So we thrombosed this completely, and you can see how the waveform with color Doppler has improved quite remarkably. And this is to show you the post-thrombosis. This is pre-thrombosis. This is post-thrombosis of that. And this went down in size, and there was a little complication of skin ulceration, which healed over time. And this was a good outcome. So I think Suresh already mentioned this, that how do you differentiate congenital hemangiomas from infantile? What's the difference? Classic sort of American Board of Radiology questions and multiple choice question is that they don't have GLUT1 positivity is what I was trying to show over here. Okay, my last case, case number 12. This is a child who ingested this particular foreign body. And the question here is, look at it carefully. This presents to you at 11 o'clock in the night. When should they remove the foreign body? Should they wait and watch? Should they wait for 3 days? Should they do it at the earliest, even though it's middle of the night? Or should you do a hemorrhage maneuver to sort of diagnose it? Any answers? 3 days? Number 3, perfect, yeah. And why? Because you can see this lucency. This is a button battery. Let me go back. This is very important. You should never, ever miss this because this can kill a child. Happens every few years, even in hospitals like mine where people wait on it for a few hours, and then the outcome is pretty bad. So here, this is a great video. I hope I can show it to you from the Australian, one minute, let me show you. Oh, it doesn't work, sorry. Is it working?
I was about to say perfect timing.
Okay, we'll stop over there. But if you want to look at that video, what they did is they took a button battery and put it in a piece of chicken, and then they timed it. Within 2 to 3 hours, you can see there's acid leaking, and it causes severe damage to the piece of chicken muscle over there. Just to tell you that be aware of coin battery ingestion, and make sure that your ENT surgeon or whoever is operating on it, go after them and make them do it right away. Thank you so much for listening to me.
Thank you so much.